Thanks. Wow, good morning. What a terrible task they gave me by speaking now after this opening session. I'm still shaking with the emotions of what I heard. So thank you guys again for what you did, what you said. I happen to know the colleagues here from the IIMHL. It took me some time to learn how to pronounce it. I met them a couple of years ago, and so soon after I was appointed director of mental health at the WHO, I was invited to come to this meeting, and because of the friendship that I feel towards them, I said yes. But then it's only recently that they gave me this title of what I was supposed to talk about, so I was tempted to withdraw my acceptance. So this is to say, do not blame me for this subject. But I will try to do my best. And because as you understood already, English is not my mother tongue. My country flag is there in Argentina. The first thing I did was to go to a dictionary or Wikipedia to try to find out what are we talking about when we talk about disruptive innovation. What is this concept? And what I learned is that we are talking about a word that is not, in my view or in my understanding, it is not our word. Business theory, market and values, again, economic and business aspects. And so I was wondering, what do we have to learn from there, or why do we need to look at a word that is so far from what we just heard this morning? The inner feelings, the inner emotions that come to our mind when we talk about mental health, disabilities. What do we have to do with that to relate to those concepts? And then when looking about accountability, the definition, it's also coming from the economic word, but the definition talks about being called to account for one's actions. And while reading and rereading these definitions, I was thinking, what is the word that we can use to talk about the no actions? What is the accountability of those who do not do what they are supposed to do? I think, and I'm sure we all agree, that we have enough technical evidence, even economic evidence, telling us what we should be doing, but nevertheless we are not doing that. So who is accountable for that, for the things not being done? So when thinking about the third part of the equation, that is the global perspective, I thought about the concept of instead reverse innovation. And the bench that you see there is called the Friendship Bench. Many of you have already heard about. I see heads nodding, and it's a project developed by a colleague in Zimbabwe, where he trained, the project is based on evidence, scientific evidence, trained non-mental health professionals on a very specific problem-solving therapy. Initially were grandmothers, the ones trained, to offer support to those who need it. And then New York Thrive, I don't know if it's, I didn't see Gary here, but there may be other colleagues from New York maybe, who in a way incorporated that and developed their own colorful benches with the same idea of task sharing and of shifting or involving others in the community who may know better what to do. Again, a grandmother we heard about this morning, right, earlier. Last week then, I was in Lille, in the north of France. And then I was introduced to an exquisite, if I can use that word, a network of mental health services that provide every kind of answer to the needs of people related to mental health, changing a bit the old approach of old-fashioned psychiatric institutions. And this is one of the services. This is the inpatient unit that was that I visited, where persons in crisis have the opportunity to be hospitalized in this facility for a few days, as long as they need, but also people in the community may come for treatment. And this jacuzzi, or I don't know exact name, is one of the options for treatment. My face, I'm not in the picture, but my face could be the same of that lady there that is ready to jump and say, I want to be treated here, right? But while being there and learning more about the situation in Lille, but also in France, or the concerns that some colleagues that were present during the visit from other areas in France were expressing, I was recalling some services that I have the opportunity to visit and to work with colleagues there in Peru. Peru that has started a few years ago to develop a network of services in a very modest way. You see there are no fancy facilities, but just neat, clean and welcoming situations that perhaps what is more important could be replicated, could be expanded. And when the first mental health center was opened in 2015, right now the whole country is covered in a way with those services, and many more different kind of services are being created. So what can we learn on the other side? How can we make sure that there is a good way of using the limited or not so limited sometimes resources that we have in order to make a more efficient use of those resources? Efficiency as in not trying to invent any definition, but as in the best that we can offer to the community we live in. And so another possibility that I was thinking about when considering this idea of the innovations, whether they are disruptive or reverse, is this area of work that is being developed. And this is us, but there may be WHO, but there may be many others in the same process, based on scientific evidence again, piloting tools with the best knowledge we have, but making tools or interventions available at a larger scale. The possibility to make the best of what we can offer, what we can come up with, to a broader community and to a larger community. Oops, the map is not showing. Anyway, I'm sorry for that. There was a map here. Because what I'm talking about is about the rights. The right of people with disabilities, whether they are physical disabilities or mental health related disabilities. Psychosocial disabilities are called in the context of the UN Convention of the Rights, it's an S missing, of persons with disabilities, which means that at some point the United Nations has to come up with this, and there are, in the map was showing how many countries, 180 countries, have signed, ratified the convention, which means that for all those countries in the world, these rights are a law. And we have to come up with that tool because the rights of people with disabilities were not being considered. So it was the need of something extra, an extra effort to make sure, and still is not that happening perhaps, but the tool is there to make sure that the right to legal capacity, the right to live independently in the community, the right to health are respected, considered, included. And we are talking about access, we are talking about inclusion, we are talking about basic issues that are not so basic when are denied to people. Sorry for the missing map, but then I thought I will bring then another big commitment that is the mental health action plan that the WHO has developed, and that has this component of accountability from a global perspective. 194 countries, 194 ministers of health at some point, Department of Health, have agreed that mental health is a priority and have agreed what are the areas that we need to work on and what are the targets to achieve. Well, guess what? We didn't make it. So this year it was decided that we need 10 more years in order to be sure that we'll get there. And perhaps when thinking and rethinking, and so many times I thought about what message I wanted to convey here to you, coming from very privileged situations, is that we know a lot. We know a lot more than what we do. A lot more of what we do in small areas could be expanded, and we can reach many more. The examples, the stories we heard this morning are of common people that have come up with strategies, and what do we need in order to involve others to come up with similarly powerful strategies, and that at the end of the day, we can't leave mental health or disabilities in the hands of specialized professionals. This goes way beyond. And then recently, we talk about a momentum for mental health. We talk about some political interest that is on the rise. And you see in that picture, the guy with the glasses is my boss, Dr. Tedros, the Director General of the World Health Organization. Next to him is the United Nations Secretary General, who is also talking about mental health, and he's also saying, guys, and he says that guys to presidents and prime ministers, he says, guys, mental health is important. Hopefully they will hear to them, they will listen. And then in the next picture we have Prince William, we have the Prime Minister of New Zealand before the very sad event that happened in her country. She was already interested in mental health. And next to her is Dixon Chibanda, the guy who created the friendship bench. And then we have the Queen of the Belgiums in the bottom, and then we also have celebrities. And the last photo, not me, but the blonde lady next to me is a celebrity, Cynthia Germanotta. I don't know if you know who Cynthia Germanotta is. Maybe some of you do know. But for those who do not know her, she is Lady Gaga's mom. So my next sentence was, if you do not know who Lady Gaga is, go Google her or talk to your sons. But Cynthia Germanotta has become the WHO Goodwill Ambassador for Mental Health. And so that is how we are also trying to provide the opportunities to spread the voice, to share a message that mental health is way more than a disease managed by mental health professionals. We need to go beyond that. This week, last week, you have also heard, and this is not, this is serious, is a hurricane in the Bahamas. And the day after the hurricane hit, or 2 days after, I turn on the news and I hear this lady saying, we need mental and emotional assistance. Please help us. And we know that that's important, right? But what shocked me perhaps is how this political interest and this momentum is felt in both ways, those in power but also the community. How do we make that match? How do we make a bridge? How do we make the knowledge and experience that is in this room more democratically spread around? To finish with my boss sentences, I think summarizing a bit this need of mixing the professional knowledge, the technical and scientific knowledge with the need of a universal coverage. We need to make sure that mental health is there, that care for those who need is available. And this is a strategy that we are working on. The universal health coverage has also mental health as part of it. So thank you very much. So that was me. Now it's you. So we come up, I'm sorry, we have come up with these two questions because as maybe you know, some of you know, and I mentioned earlier, I was recently appointed director, so I need a lot of help. I didn't have time to think much during these 8-9 months because it's busy out there, and so I need your help. Please help me with these questions that may help us moving ahead. You understood the organization and the time you will have in each table. Hopefully you also identified who will be your rapporteur. In the meantime, the questions are those. What one disruptive innovation can you share that you have led or experienced? And the second one is, why are mental health, addiction, and disabilities fields still fighting for parity and inclusion? You have your apps. You have also the possibility to share those with me. I will be looking forward to learn from your inputs, and we're all going to be doing it right now. Thank you.
So at this time, we're asking you to discuss at your tables for the next 20 minutes or so, and then we'll come back with responses to the questions.
We have 15 minutes now to share some of the discussions, conversations you had. And you know that from up here, when I spoke before, I thought there was a mirror there and that we were reflecting the rooms in the back. And then I learned that there is no mirror, there is plenty of people in the back room. So, hey, so to honor their presence, why don't we start from the bottom of the room? Who wants to share the discussion? We are not going to focus on one first and then the other. Just let's talk about question 1 or question 2 as you feel it. I'm inviting somebody there. Who wants to? Yes.
Talo Falava, kia ora. My name's Josiah, I'm from New Zealand. We had a table mixed with New Zealanders and some Norwegians. Yeah, woo! If I'm to summarise 3 things that we said from that first section, we had a mental health policy inquiry into mental health and addiction last year, and that brought a lot of people together to think differently for organisations to work. So the disruption was sharing the power from government level so the community could make the right decisions that needed to be made. We heard about disruption that's negative, and in a Norwegian example where there was a year-long sick leave approach, and it got removed, and now people who had this right have to go on social welfare and aren't allowed to own property or anything else. And so rebuilding from disruption can be tough. And so the question we had there is, disruption, but from whose perspective? And then the third thing was we have to challenge things like discrimination, and we have to call it what it is. And in the last 24 hours in New Zealand, we've had an interim mental health commission appointed, and in their terms of reference, racism is written as something that must be called out, which is fantastic. But one thing that at our table we talked about is we can have disruption, but we must do it in a way that's mana enhancing. So in Aotearoa, we talk about not losing someone else's dignity or their influence and putting them down. So we can do both things together. Whawhata, thanks.
Thank you. Yes, a lot to learn from there. Who wants to? Yes.
So I think, hi, I'm Fredrik Lindgren from Sweden. I think we wanted to disrupt the format. So I'll say a few words, and each of my friends here will say their own, because we didn't integrate. We just brought a lot of conversations up and hope we can do that. So my personal thing is that some of you remember the theme from last year, building bridges beyond borders. I think that's, to me, the whole sort of concept of doing both reverse innovation and disruptive innovation, because the whole idea of seeing in a system what kind of mind shift you have to do to really address underlying things and reshape how, like you so clearly showed it from Aotearoa, the way we're putting racism or other things on the top is actually shifting our minds, and then that helps us to see other innovations that will make it happen. We can't innovate if we don't change our mind shift, or mindset, I think, at least for a longer way of working. So in our case, for example, there's been a lot of understanding that international work is essential for your home work at home, and several other things like that. So that's my reflection, and do you want to say a word?
Well, Chris Klein from the States, Arizona in particular. So just a general commentary, we talked about many types of disruptions. And I think overarching to our conversation was how important that the disruptions lead to actual cultural shift, not just disruption of that particular phenomenon that's going on. And I think we had examples of those things that came from, if you have, for example, state leadership, if you're involved in a process where you have a relationship with, say, for example, providers in the world, whether you're working with peer support and recovery movement, and how important it is to look at, what is the essential change that's happened. And I very much appreciate over here the man from New Zealand who says, from whose context? So I think that's an important thing that we talked about. So any other colleagues?
I'm just going to quickly say one thing, and I want to mihi to Whaia Moi, who I hope's in the room, because one of the things that she talked to us about from an Indigenous perspective is to take our power back. So in Aotearoa, New Zealand, we were very fortunate to lead from those of us who are Māori with lived experience to lead something called Tūmata Kōkiritea, which is about shifting the paradigm. And that's about being led by us. It's a change management framework that we've developed that says, actually the stuff's happening to us, therefore, let us be the change and let us be the ones that change what's happening out there. So, kia ora.
We can move a bit to another corner to get another perspective in case you are sitting together there and confabulating with each other. So I have a hand here raised, please.
Hi, I'm Paul Burstow, and on our table we have a mixture of colleagues from the United States, from Sweden, and we discussed the two questions. I'm just going to try and summarize a few of the points, and others will shout me down if I've got it wrong. We talked about co-production being a genuinely disruptive intervention, often not practiced, but often preached. We heard some great exposition of it today in the presentations at the beginning of the morning. We had a great example of in Texas where they have a policy fellows program that historically has had access criteria. You have to have a master's degree to be able to go on these programs. They've now removed that criteria and said that if you have lived experience, that's equivalent to a master's degree. We want you on these programs, and that's having a big impact, a really great initiative. We also heard in the UK about the Children and Young People's Thrive programme, which is about saying we should no longer use diagnostic labels as the basis for determining access to mental health services. We should approach it by looking at the lens of need and strengths and use that model when it comes to working across agencies, social workers and others. And then finally, in terms of the second question, just two things really. One is follow the money. And the money currently flows in the way we've designed our systems historically to work, and it is about spending the money too late. We spend on consequences, we fail to spend enough on causes, and that has to change. And then finally, the need to actually realize that we are very often the prisoners of the rules we've made ourselves, and we have to change the rules if we're really going to deliver the great mental health strategy that the World Health Organization is advocating.
Thank you, thank you. Another hand. This corner?
Kia ora, my name is Anil Taplial. On this table we got colleagues from United States, Canada and Australia, and myself from New Zealand. We just talked about disruption being the e-mental health, the role of digital technologies in providing care, early brief intervention. So we were sharing some of the stats in New Zealand of the total completed suicide in 2017. 77% of those people were not in contact with any primary care or secondary care prior to taking their life. So one of the challenges for health services is, how do you reach out to the people who are not reaching out to services? And one of the examples, and there were great examples from Ontario, what they're doing in Ontario shows, and Australia. But one of the examples is, which will be resonate with each one of you, after the Christchurch massacre in New Zealand, within the period of 5 weeks, there were 27,000 contacts through digital means. So that's physically not plausible to do through normal services. So there are some good stats and good data around what that context of that was. So e-mental health across, not just for clinical intervention, but also looking at the promotion and prevention as well. Thank you.
We are getting a nice variety of answers. Who else wants to? Yes, at the bottom. Somebody's.
Good morning. Our group was made up of the United States, Canada, Australia, New Zealand, and we got along surprisingly well, given that. And we talked, kind of lumped question 1 and 2 together in some ways. We talked about the disruption being the higher expectations of people with mental health diagnoses and disabilities. That some examples we talked about were the expectations around people working and going to school and living independently can be actually disruptive to the systems that serve these populations that we're working with, and how that's really a lot of ways tied to funding, of course, and what we actually pay for, and the way that our services that we are actually fighting over small scraps was one of the themes that came out of our conversation. So kind of pitting even mental health and physical disability against one another for small pieces, as opposed to looking at a larger piece of the puzzle, or a larger piece of the funding pool, I should say. And that a lot of that, of course, is tied to attitudinal factors, that we have these low expectations, there's stigma, people don't even think of a person with a serious psychiatric disorder or a physical disability as somebody who would be working and leading a productive life and so forth. So I feel like I missed some points.
Yeah, the underlying theme that we sort of merged the two questions together, why are we fighting for parity? And the bottom line is funding. We're all fighting for the same resources. And the particular group I belong to has actually taken its inspiration from the Australian National Disability Insurance Model, which strikes me as the most universal, comprehensive, and rational kind of approach to funding for all our needs. And it also takes it out of the welfare model and takes it into an investment model. But I think bottom line is a lot of these issues are related to funding and the way we fund and the mechanisms and means through which the money flows, as was pointed out over there. So I think from our perspective, at least, the universal medical coverage that you spoke about, it needs to happen for people with disabilities.
Thank you. I would say one more. Who's the last? Here. Front here. Who's coming with a microphone?
Oh, there you go. I thought it was.
So we had Canada, New Zealand, and the United States, of course, who recorded for us. One of the things that we thought was actually a great potential to be disruptive is the I Circle Thrive Cities movement. because it is mainstreaming mental health. It's a population health focus. It doesn't matter whether it's the workplace, the school system, service improvement within systems, but it basically ties to human capital and quality of life. So we think that can be a potential game changer for the world if we get it right. And just, even in the developing world, the Cities Rise movement is doing some amazing things in places like Chennai and Nairobi, so it's got spread. To the question about why not mental health is thriving in the world, I think we came to the conclusion that it's because it's been traditionally about them as opposed to us. So you start with the 20%, and actually the Mental Health Commission has some statistics that suggest that by the time we're 90, 70% of us will have experienced some form of mental health issue. So I think it's really to talk about this in terms of the us and also focus on mental well-being, not just mental illness.
Thank you very much. And we are finishing. There's no point summarizing. I'm sorry, the clock is, do we have time for one more? One more.
This is from Marlene and I, from our death exchange. We spent 2 days in Gallaudet, so I'm really feeding back from our group. And to the first question, I would say turning things around about actually the majority of people, non-deaf, actually listening to what deaf people say and our experiences, deaf people just overlooked. We disrupt by sometimes just going into a room because everything has to change so that we can actually be accommodated. And one of the things I want to say is everybody needs to be able to feel uncomfortable, get out of your comfort zone. Because I meet a hearing person and they, oh. One person from this conference so far has actually asked me, how can I help you to understand me? And that is fantastic, exactly what we need. But 2 examples from our exchange. One was a professor from Gallaudet University, deaf himself, from Japan, and he talked about disasters, when disasters happen, and disaster planning, which some of you guys have already mentioned. And deaf people overlooked. The highest mortality rate from disasters can be deaf people. Why? Because they're not thought about. So disaster planning has to involve deaf people, be deaf and deaf leaders involved in disaster planning. Because deaf people know each other, we know where we are. So all communication to down, deaf people can contact, or they know where deaf people live. So that has to be built into disaster planning. The other example is really going back to my early days as a social worker, when we worked with deaf families. And fortunately, some deaf families with deaf children, so the deaf babies were learning sign language from right on. And really good, developing very good language, whereas deaf babies from hearing families didn't develop language too much later on. And there's a lot of evidence of mental health problems developing later on, where deaf children are not given access to early sign language. But now going to Gallaudet, there's actually research now in neurology research to show that deaf babies need sign language very early on. So why won't deaf people listen to? Why? We have to wait 30, 40 years down the line for the actual research. But we know from anecdotal evidence, from seeing it, that deaf babies need sign language. Okay. And the second question is, I've forgotten what the question was, but it's about, people have already said it's about power, it's about resources, it's about professionals getting very comfortable, not wanting to, big changes and feel uncomfortable. So we need to listen. We need to listen. We need to be able to put ourselves out of our comfort zones, learn from others.
what's a better way to close this session? Thank you, everybody. The answers and the comments are in the app, so let's look at them. We all going to learn, definitely me. Thank you.
No, thank you. Thank you.